pleasure for the course on behalf of the course organization, and it is a pleasure for me to be in the head of that program tonight. I would like to give the floor to Professor Assam Manna to offer this honor to present it to Prof. Samir Ansari. Professor Assam.
Thank you so much, Professor Saad. Uh, really, dear colleagues, really tonight we have a ceremony. The organizing committee of Anesthesia Mega Online course and all of the attendees and the panelists are celebrating with our course legend, Professor Samir Al-Ansari. Of course, we have in Egypt symbols and leaders we are proud of. Of course, in politics, science, arts, and etc. I consider Professor Samir Al-Ansari is one of the symbols and the sure one of the leaders in anesthesia and intensive care in Egypt, and sure in the Middle East. No doubt, his experience and presence in our course adds a huge and great value. Actually, from my deep heart, I wish for him long, long life, full of happiness and health, Prof. And on behalf of the group, please, Professor Ansari, accept a very simple appreciation from our group, the Shield of Excellence of the Mega Medical Academy. And I think the best person in the academy who deserves to introduce this shield is Professor Saad Mahdi. So please, Dr. Saad Mahdi, introduce the shield for our eminent and expert professor. Thank you so much.
Thank you much, Professor Assam. I can't say any more after you said what you said. Really, the accreditation of this course basically came first for Professor Samir Ansari, who offers to lecture with us and lecture through this platform to everybody. It was a great accreditation, and he gave us what you call resuscitation for that course, life kiss for that course. Whatever you say is never been enough for Prof. Samir Ansari. I'm really overwhelmed by his giving. So far, in 26 episodes in the course, we have received 9 lectures from Professor Samir Ansari. Whatever we do is not enough to say thank you very much for Prof. Samir Ansari. Thank you.
Really, I am highly happy from this appreciation, but I want to say something. My appreciation already received, already Dr. Saad received, since you give me chance to participate with this highly educated and highly polite team and this famous construction, which I hope to see it as a huge construction all over the world, inshallah. You are really a good family, a good members, a good friends, and a great offer for me. And the words are greater than my caliber, really. I'm highly happy from this appreciation. Thanks for you.
Thank you very much.
You make now, I think I can't deliver my lecture from this emotional situation. Thanks for you. Thanks for all.
We believe that, Prof, that we are born again today. That course is starting again today. And thank you very much. The second...
Prof, we are so proud of you, Prof. Ansari, and we considered your lectures as references for many people in Egypt, in Middle East, and all over the world. So we would like to appreciate and thank you for your effort and your endless bestowal all the time. Thank you, Prof.
The second, on behalf of the course organization, I really wish in a position to give an honorary appreciation for every lecturer in the course. But the second appreciation is getting to Prof. Makarita, and Dr. Mayada Yahya is going to introduce it.
Assalamu alaikum. Good evening, everyone. I am Mayada, lecturer of anesthesiology and intensive care, Azhar University. It's a great honor and pleasure to attend this mega online presented by our distinguished doctors, professors, Dr. Samir Ansari and Dr. Makharita, who updated us with valuable information and enriched our skills by their experience. I would like to thank them from my heart with deepest, dearest, valuable, informative, and amazing lecture of you. Thank you, Dr. Makharita. Thank you, Dr. Samir. We really appreciate you. Thank you. Thank you for both of you. In Arabic word, جزيتم الجنة إن شاء الله.
Dr. Hisham Abdul Maqsood, would you like to add anything, please?
Yes, of course. I would like, of course, on the behalf of every attendee before the panelists, to thank everyone who participated and who gave us even small minutes of his precious time to complete the nice picture and give this work the ultimate and complete picture that it's appearing now to everyone. And this work, I believe that it will not only be beneficial to the attendees who are attending and of course getting a lot of benefit to this, but it will be also beneficial and of great help to the next generations of our juniors and doctors, anesthetists, intensivists, and pain doctors from the coming generations, inshallah.
Dr. Walid Aswa?
Yes, sir. Yes, sir. I will say words and feelings lives 100 years beyond our lives, and however we use words to tell about Professor Samir Al-Ansari or Professor Muhammad Makharita, we cannot get them their rights. So we appreciate so much your support, Professor Samir, and your support, Professor Makharita. Thank you from all. Thank you.
Professor Makharita, if you please, Dr. Saad, I'd like to introduce something about Professor Makharita, because he is well known an expert in anesthesia and in pain management in Egypt. He well known by his great efforts in the field of pain and his experience in pain, and he is well known everywhere in the universities of Egypt and also in the Middle East. And I think he's making a great effort in the Egyptian Society of Anesthesiologists. So I'd like to appreciate his job and introduce him and say thank you, Professor Makharita, for your effort. And inshallah, everybody will get benefit from your lectures and all the mega academy as reference for the whole anesthesiologists all over the world. Thank you so much.
I wish I'm in a position to give a speech to every panelist and even attendees. I would be very happy. Prof. Samir, do you want to say anything?
I want only to say something. Yes, I suspect and I hope and I am sure your mega course will be the most famous one, inshallah, all over the world, with your effort and with your help and with your hardest work which you spend in this field.
Thank you.
Good luck for all of you. Good luck for all of you.
Thank you. I would give the floor to Barbara Roger, our guest from Ohio. And I'm so pleased to have her tonight. Yes, sir.
أنا عايز أقول بس شكرا. Thank you very much for your kindness.
You know,
And
our relation
for
to
all.
you, Prof. Makarita, is more than friend and more than
جزاك الله
speaker here.
خيرا. جزاك الله خيرا وجزيتك.
You well
شكرا
deserved.
شكرا
Well
حضرتك.
deserved. Well deserved.
شكرا.
Barbara, all yours now. Thank you very much for coming from Ohio to introduce in this course. And it is another milestone to be across the transatlantic to reach Ohio through Barbara Roger. All yours.
Welcome, everybody, and thank you, Dr. Mahdi, for giving me the opportunity to be involved in this wonderful course. Our first lecturer is, as everyone knows, the eminent Dr. Samir El-Ansari, Professor of Intensive Care Medicine. Hello. And he's going to talk about muscle disorders in the ICU. Thank you, Professor.
Okay, thank you.
Do you mind, please, if we take the question after each lecture, because it will be easy for video editing?
Okay, so when Dr. El-Ansari is done, we'll take like 4 questions off the chat box?
Yes,
Okay.
please. Yeah, thank you.
Wonderful, thank you.
Thank you. Bismillahirrahmanirrahim. Thank you all. Thank you, Dr. Barbara, for this nice introduction. And good evening, our colleagues, and good evening and welcome our attendees. I am going today to speak about some of the common problem in the ICU, which is muscle disorders in the ICU. Really, all the muscle disorders in the ICU share the same problems or the same considerations, like how to diagnose or difficulty in diagnosis and how to manage and the restricted routes of management and so on. Today, I am going to just highlight the most common causes or most common underlying disorders which we face commonly in the ICU. Of course, if we start from the central nervous system, or maybe brain injury, or maybe spinal cord injury, and going down to nerves, maybe some sort of disease affecting the peripheral nerve, like Barré syndrome, critical illness neuropathy. Also neuromuscular junctions as myasthenia gravis, botulism, tetanus. In the muscle, ending to the muscles, we can see polymyositis, myopathy, intensive care myopathy, and I think we know there are many diseases affecting the muscles and affecting the neuromuscular unit. And as most of us know, there are maybe more than 600 diseases affecting our nervous system. And so the differential diagnosis really in this field is highly difficult. And the diagnosis also may be difficult to some extent at start. We have to, and also even the facilities or the lines of treatment is restricted and highly costly. If we start with a common disease, which is Guillain-Barré syndrome, and as we know, this disease is maybe diagnosis and the management of it may be complicated. And its clinical presentations and disease course are mostly heterogeneous, as we will see. And so the international clinical guidelines are currently available depend on some literatures, depend on case study, depend on some expertise, and so on. It is an acute onset, always starting acutely, and some cases, some start with chronic presentation. The acute onset starts with ascending sensory motor neuropathy affecting the periphery first and going up. And it is an acute inflammatory demyelinating polyradiculoneuropathy and mostly demyelinating, but some item or other types affect the axonal nerves, as we will see. It is a rare disease, but potentially fatal disease, and it is immune-mediated disease. of the peripheral nerves and nerve root that is usually triggered by previous infections, even subclinical infections, some infection with influenza, maybe cytomegalovirus infection, Epstein-Barr virus, some pneumonia, and even with vaccination, especially vaccination against influenza. The body started forming antibody against the gangliosides, which reside at high density in the axolemma and other component of the peripheral nerve, and also in association with complement activation and infiltration of macrophage and edema are typical characteristic of affected peripheral nerve and the nerve root in patient with Guillain-Barré syndrome. There are 10-step approach to diagnosis and management of Guillain-Barré syndrome. If we look to this figure, it simplifies actually how to diagnose, how to proceed, and how to manage this disease. And I think we have to apply these steps in most of the muscle diseases. And most of our talk today about Barré or about botulism or about another disease, it I think apply to most of the muscle diseases which you face in the ICU. How to diagnose the Barré syndrome? It is a rapidly progressive bilateral limb weakness, and it may include also sensory nerve affection, and also maybe hyporeflexia. Most of the cases excepting hyporeflexia or areflexia, as in Miller-Fisher, also may extend up and causing some sort of bulbar palsy and facial nerve and cranial nerve affection, causing ophthalmoplegia and ataxia. How to diagnose Barré? Check the diagnostic criteria, and most of the muscle disease, we apply these points also. Exclude other causes of the muscle disease, consider routine lab test and the CSF examination, specifically in Barré syndrome. It will show us increased, in most cases, increased protein, may be normal in the early stages, but after that, we'll accepting increase in the protein level in the CSF. But the cell is there is no increase in the cells, there is no biliocytosis. Also, the other lab tests must be done to exclude other causes of the muscle disease. See, electrophysiological study, this must be applied in any muscle disease. We can see the latency of nerve action potential, conduction. We can see F wave. We can see many characteristics for the post-tetanic potentiation, post-tetanic inhibition. It helps us in differentiation of the different type of muscle disease. Because muscle disease really, it may be difficult in diagnosis sometime, especially in the early stages. When to admit the patient to ICU, when the patient is starting to accepting some sort of respiratory impairment, or he is going to respiratory failure or respiratory distress, or the patient becoming to accepting progressive weakness and severe autonomic dysfunction or dysautonomia is one of the commonest factors which causing us to admit the patient to ICU, because it causes high mortality. When to start the treatment for the patient, really there are different opinions in this field. Some prefer early intervention, especially by plasmapheresis or by infusion of immunoglobulin in such cases. Others ask to wait till some weakness or some evidence of the disease becoming clarified and becoming evident. Treatment options in Barré syndrome, as we know, it is limited and it is restricted to intravenous immunoglobulins, 0.4 gram per kg daily for 5 days. For children, we can give this dose over 2 days, not 5 days. Some prefer it and some prefer over 5 days. Plasma exchange also the dose 200 to 250 ml per kg for 5 sessions. And some ask if we can repeat this treatment if the patient accepting slight improvement or accepting not dramatic improvement. Yes, we can repeat after some times in some patients who accepting some deteriorations after the initial treatment. Monitoring also, as in many muscle disease, we have to record the muscle strength, how the progress, the respiratory function, especially through spirometry, vital capacity, forced expiratory volume, different pulmonary function tests to evaluate the progress of the disease. Also, we have to look to the swallowing functions and the difficulty in swallowing or getting rid out of secretions, especially in cases of cranial affection of the Barré syndrome. Also, the autonomic functions is very important. And as I said, this autonomia and severe arrhythmia in some cases during evening positioning of the patient or moving the patient, exhibiting fluctuations, severe fluctuations in heart rate, blood pressure. Also, they may complaining of bladder, bowel control problems and so on. We have to look also to the complications, especially early complications in Barré syndrome and also in any muscle disease, really. We have to be careful for DVT, prophylactic anticoagulant to avoid DVT for those patients because they are not ambulating and the muscle tone is low and the DVT is common. Also, we have to look for choking and aspiration and atelectasis and so on. So we have to guard against and we have to intubate the patient early. Infections also is very common, especially pulmonary infection, deep venous thrombosis, pain. In some stage of the disease, most of the patient with Barré syndrome suffering from some sort of muscle pain. Also delirium and depression, very common in all muscle disease and specifically in Barré syndrome. Urinary retentions, constipation, corneal ulcerations, where we have to protect the eyes and take care of the eye. Dietary deficiency, very common, and very common in ICU to see patient with malnutrition, which predisposes to critical illness, myopathy, and cachectic myopathy, which may be difficult to differentiate from Barré syndrome in some situations. Pressure ulcers is very common and it depends on good nutritional state and also in positioning of the patient, physiotherapy, hemodynamic state. All these factors affect the development of pressure ulcers in those patients. Compression neuropathy, very common in such patients because basal tone is very low and they are liable for compression. Limb contraction, and so we have to move the joints and to ambulate the patient and to participate with, ask the help of physiotherapy to avoid these complications. Monitoring, as we covered that, clinical progression is very important with treatment, and we check if the treatment giving us a good result, or we have to repeat, or it is not optimal. And repeating treatment, but some, as I told, we sometimes repeat the treatment if there is some response and if we suspect there is progression of the inflammatory state of the disease. Predicting outcome and long-term care, it is very important also, especially in Barré syndrome and in all muscle disease patients, especially the psychological state and the lifestyle after that. Most often, unremarkable infections precede the Barré syndrome. Mostly the patients complaining, especially of Campylobacter jejuni. Can be in a quarter of our patients, they suffering from previous Campylobacter infection, Zika virus, as here before, cytomegalovirus, mycoplasma pneumonia, Epstein-Barr virus, influenza virus, and some vaccination, especially against influenza vaccine. Mostly influenza vaccine, some patients and some vaccines exhibiting this. Absence of antecedent illness doesn't exclude a diagnosis of Barré syndrome. Suppose the patient is not suffering from previous infections. This is not meaning the patient has no Barré syndrome. May be some sort of autoantibody or autoimmune reaction to other factors. Barré syndrome is usually begin abrupt and especially the distal and symmetrical in most of the cases, and start also with paresthesia and quickly followed by progressive limb weakness. Progression is rapid really with 50% of patients reaching clinical neither by 2 weeks and more than 90% by 4 weeks. If I find my patient developing weakness and paresthesia and within 24 hours or after 4 weeks, this is not Barré syndrome, and I have to search for another cause of the problem of in such patient. Always it takes from 2 weeks to 4 weeks to give me the full picture of Barré syndrome. Before 24 hours or after 4 weeks, accepting the patient morbidly after 4 weeks, this is not Barré syndrome. In patients who reach maximum disability within 24 hours of disease onset or after 4 weeks, alternative diagnosis should be considered. 80 to 90% of patients become non-ambulatory during the illness. Pain is prominent in 50% of patients. Distal symmetrical weakness. Reflex is decreased, reflex action is decreased or absent in most patients at presentation and in almost all patients at need. Most of the patients, excepting some, but I want to say Barré syndrome is highly difficult disease in its diagnosis because there are, as we will see now, there is an overlapping symptoms. It is not distinct symptoms or accurate symptoms, or we can't say it is consists of paresthesia or ascending or descending or cranial only or dysautonomia. No, we have in many patients a different figure of presentation and different pictures of presentation as we will see now. Although Barré syndrome is essentially a motor neuropathy, sensory dysfunction is seen in few patients. And sometimes we see sensory manifestations only in very rare cases of Barré syndrome. Facial or pharyngeal weakness is commonly seen in Barré syndrome. Diaphragmatic weakness also, due to phrenic nerve involvement, is also common. Dysautonomia is one of the most problematic complaint in Barré syndrome: hypotension, hypertension, arrhythmia, tachycardia. As I said before, just you manipulate your patient, moving him from side to side, he may be arrested in front of you. And so take care of this autonomia and some other diseases, muscle disease, excepting this dysautonomia. And I think you saw it also in acute cervical injury and in spinal cord injury. Axonal subtypes of Guillain-Barré syndrome may be manifested as a pure acute motor axonal neuropathy, just the motor nerve affected, or acute motor and sensory neuropathy also we can see. It is caused by antibody which attack the gangliocytes at the axolemma of the nerve and also participating with complement activation and the invasion of microwave to the axolemma and causing edema of the nerve and in some other types demyelination of the nerve. About quarters of patients with Barré syndrome had Campylobacter jejuni infection, and so try to check this microbe. Diagnosis: progressive weakness in both the upper and lower extremity within 4 weeks, along with areflexia is essential requirement for diagnosis. An elevated CSF protein concentration with normal cell count, not exceeding 50 cells per milliliter. And so no peliocytosis and Barré syndrome. But suppose you find that tapping the protein level is low, maybe you can't exclude the Barré syndrome. As you see here, the pattern of symptoms in variants of Guillain-Barré syndrome, we see many different patterns, about 25 or 30 patterns really. This pattern, I just summarize it. We can see the classic sensory-motor affecting motor and the sensory nerve affecting the body, all the body. Maybe pure motor only, and maybe paraparetic. The patient look like paraplegic. Sometimes we think it is a spinal injury and causing motor and the sensory affections. We can see also the area of the bulbar area or the pharyngeal area with cervical and brachial and arm weakness and sensory loss in the upper arm, and also with dysphagia and weak coughing and so on. It could be in another pictures bilateral facial palsy with paresthesia in the distal area of the limbs, or maybe pure sensory, and it is very rare, pure sensory really. Or in the form of Miller-Fisher syndrome, which consists of ophthalmoplegia and areflexia and ataxia, 3 items. Ophthalmoplegia affecting the eye muscles, and also ataxia and areflexia, no reflex action. If this type lost consciousness, or if becoming drowsy, or affected the consciousness, or becoming not concentrating also, it will be Baker-Stuff brainstem encephalitis, and the pyramidal area or the brainstem area will be affected. This is a simplified figure to show you the Paris syndrome is not a distinct entity or not easy in its diagnosis. There is an overlapping symptoms and signs, and so its diagnosis may be difficult in some cases. Baker-Stuff brainstem encephalitis also usually present with symptoms resembling Miller-Fisher syndrome, which consists of ophthalmoplegia, ataxia, and areflexia, in addition to loss of consciousness and brainstem dysfunction, including impaired consciousness and the pyramidal tract signs. Features required for diagnosis: it is a Paris syndrome. To be sure, it is a Paris syndrome. Progressive bilateral weakness of arm and legs, initially only legs, may be involved. Absent or decreased tender reflexes in the affected limb. Pain is prominent in 50% of patients. Relatively symmetrical weakness. Progressive, this is the most figure or most characters of Paris syndrome. Progressive phase lasts from days to 4 weeks. Relative symmetry of symptoms and signs. Relative mild sensory symptoms and signs. Cranial nerve involvement, especially bilateral facial palsy. Autonomic dysfunction, muscular or radicular back or limb pain. Increased protein level in CSF. Normal protein level doesn't rule out the diagnosis. Electrodiagnostic features as latency and delay in conduction and F wave and so on, is characteristic to Paris syndrome. But we have to raise the red flags and start to think in another problem, not Paris syndrome, if we find these points. If the fever is at present, a patient present with fever at onset of the disease. If there is severe pulmonary dysfunction with limited weakness at onset. If there is severe sensory signs with limited weakness at onset. If there is persistent bladder or bowel wall dysfunction or bladder or bowel dysfunction at onset, or sharp sensory level, maybe spinal injury, or marked persistent asymmetry of weakness, always Paris syndrome symmetric. Lab also increased number of mononuclear cells in CSF or polymorph nuclear cells in CSF, marked pilocytosis, and in such cases we have to think in another problem, maybe some infection, HIV, cytomegalovirus, maybe leptomeningeal malignancy or other underlying cause at lymphoma and carcinoma. We have to think in another problem, not Paris syndrome, if we find this point in the patients. Not asymmetric, patient suffering from fever at start, patient suffering from sharp sensory level, and so on. Paris syndrome is a monophasic illness, and although so many patients can deteriorate after first stabilizing or improving with therapy, sometimes you give a treatment and plasmapheresis or immunoglobulin, and the patient accepting some improvement and then deteriorate. The treatment-related fluctuation, we call it treatment-related fluctuations. And in such situations, we have to repeat the treatment. We have to push the treatment again, better maybe. And the relapses of GBS can occur in 1 to 5% of patients. And if it is relapses more than 2 or 3 times, I think it will be a chronic inflammatory demyelinating syndrome. Baker-Stuff brainstem encephalitis, as I told, it is mostly it is like Miller-Fisher syndrome, also included in Paris syndrome, which is diagnosed by areflexia, ataxia, and ophthalmoplegia, in addition to some pyramidal affections or loss of consciousness. And in such situations, maybe there are too much antibody against or too much antibody against the ganglioside in the axial lemma of the peripheral nerve. There is another figure or another disease entity of the Barré, which is acute ataxic hypersomnolence. The patient coming with drowsiness and coordination problems mostly, but no muscle weakness can be detected. This is called acute ataxic hypersomnolence. And so we saw how much this disease is difficult because of its overlapping signs and symptoms. Bickerstaff brainstem encephalitis characterized by rapid onset of ataxia, areflexia, and a disturbance of consciousness. Recurrent episodes have been reported. MRI abnormality in the brainstem have been reported in 11%. It is often overlapping with sensory motor Barré syndrome. What is the management of Barré syndrome? I think it is not for the pathology and description of the disease. As I told that first, we have limited tools to manage such disease. So we have all the intravenous immunoglobulin and the plasmapheresis, and it is very important for management. But actually, the management of complications and the management of the disease itself and the progress and the sequel of the disease in any muscle disease, not only in Barré syndrome, is very important. Avoid DVT, avoid bed ulcers, avoid good nutritional support, or good psychological support, avoid depression, avoid delirium, avoid many complications in the patient suffering from muscle disease. And it is common manifestations. The most important item in management of muscle disease in general and Barré syndrome specifically is intubation indication. If your patient has exhibiting inadequate ventilatory effort, if your patient is exhibiting poor airway protection, you decrease the level of consciousness and is liable to aspirations and atelectasis and pneumonia and potential for neurological deteriorations, we have to intubate. And don't forget 20, 30, 40 rule. 20 vital capacity, if the patient exhibiting less than 20 cc per kg for vital capacity, you have to intubate. If the patient exhibiting less than 30 cc per kg maximum inspiratory, 30 centimeter water, maximum inspiratory pressure, you have to intubate. If your patient exhibiting maximum expiratory pressure less than 40 centimeter water, you have to intubate. These are 20, 30, 40. 20 for vital capacity, 30 for maximum inspiratory pressure, negative inspiratory pressure, and 40 for maximum expiratory pressure. 20, 30, 40 rules. But really, we don't depend in muscle disease on spirometry or pulmonary function test. We depend mostly, as I told always, on clinical. Don't wait to measure, don't wait to make blood gases. Your patient will not exhibiting hypercarbia except in the late stage, except in the dying stage. He will exhibiting hypercarbia. Don't wait for deoxygenation. The muscle Barré syndrome or the other muscle is not manifested by deoxygenation. Deoxygenation and the hypercapnia and you are late signs in muscle disease. Don't depend on such investigation. You have to depend on your clinical sense. You can find, you look to your patient, he can't swallow, he can't cough, he can't raise his head, muscle power is low, muscle power. You have to arm yourself and intubate your patient. Plasmapheresis, early, and I told them, really in most of the research and in our experience, as early as possible, plasmapheresis give you a good prognosis and a good result. And even in the stage of paresthesia, if you predict the Barré syndrome in the stage of paresthesia and the patient just coming to you after some infection and complaining of some paresthesia and some weakness, weak weakness, you have, if you start plasmapheresis rapidly, your patient will be recovered rapidly. 5 exchange, about 200 to 250 ml per kg over 10 days or over 5. Intravenous immunoglobulin, as I said, 2 grams per kg over 2 to 5 days. In children, we can carry it in 2 days only, in adult in 5 days. Some pediatric prefer over 2 days. Some advise plasmapheresis for intravenous immunoglobulin, not so efficient and costly and not effective. Even if it gives you some, maybe some slight improvement, I think not mandatory or not beneficial. Steroid treatment is not beneficial in Barré syndrome. Steroid treatment not beneficial in Barré syndrome. Not been but it carry its complications, osteoporosis, infection, immune suppression, and so on. Also in acute cervical injury and spinal cord injury. Don't give steroid. No need for steroids. Treatment-related fluctuations indicated that the treatment effect has worn off while the inflammatory phase of the disease is still going, and so we can, as I told, we can repeat our plasmapheresis or repeat our intravenous immunoglobulin for such patients. Autonomic dysfunction or dysautonomia, as I told, it is very common and very catastrophic complications and lead to high range of mortality, and so take care of dysautonomia and try to treat it. These are important complications of Barré syndrome and even most of the muscle diseases. This is the most common complication. Choking, cardiac arrhythmia, hospital-acquired infection, pneumonia, urinary tract infection, bulbar and facial palsy, immobility, bladder dysfunction, mechanical ventilation, pain and tactile allodynia, depression, urinary retention, corneal ulceration. All these complications are common to all muscle disease, not only for Barré syndrome. I shift now to another problem in ICU which we face, which is tetanus, or which is caused by Clostridium tetani, and as you know, which is a locked jaw syndrome, and causes obstronus after that when the back muscle is contracted, and it starts, as you see, just with a wound here, infected wound, an anaerobic area, anaerobic medium for growth of Clostridium tetani, and then starts the muscle of the face starting to be tonic, and the patient suffering from locked jaw and rhizus sardonicus appearance, and after that, and becoming impressed in breathing. And this wound here, endospores here can be introduced in the body through the puncture wound, especially the rusty nails and the anaerobic area or urine area and agriculture area and wet area. All these carry the Clostridium tetani, which causes tetanus or causing which harbor the anaerobic bacterium Clostridium tetani. Even patients with heroin users, they can inject themselves with heroin and causing some sort of tetanus. It can carry the rusty nails. Surgical procedure also, intramuscular injection, compound fracture, dental infections, animal bites. All these can cause tetanus because it incorporates, if not clean, incorporates the Clostridium tetani. Signs, symptoms, and tetanus often begins with mild spasm in the jaw muscles, also locked jaw or trismus, and then the facial muscles become contracted and give you appearance of rhizus sardonicus, and the tetanus toxin or tetanus was being specifically block the release of neurotransmitter GABA and glycine from inhibitory neurons, and so the muscles stay in a state of contraction. And so we saw many patients really suffering from generalized tetanus. And such a patient, I advise, if you face patient in ER coming with you with generalized tetanus, don't hesitate, make tracheostomy. If you can't intubate, proceed. Or even if you can intubate, proceed for trach, because this patient will stay in the ICU more than 1 month. Because he exhibiting severe contractions and the, I think, intubation for a long time, it is carry its complications and its hazards, and so better to tracheotomize this patient from start. With the help, of course, of benzodiazepine, any muscle relaxant drug, and also with muscle relaxants, and proceed with better for the patient. Because such a patient, even when you come in front of him, when you speak to him, When you touch him, he becoming the attacks of contraction. Because the inhibitory pathway is inhibited by tetanus toxin or by tetanus plasmodium. And so no relaxation of muscle, no cholinesterase actions after the acetylcholine action. And so the muscles stay in a contracted state. It is very painful and may cause fractures in some patients. And so this, but it not affect the consciousness, and the patient is fully conscious. Other symptoms of tetanus may include sweaty headache, also dysautonomia and increased heart rate, decreased arrhythmia, hypertension, hypotension. All these manifestations could be detected in tetanic patient. Onset of symptoms is typically 3 to 21 days following infection, and may be more than 1 month. The patient incorporating the bacterium and do not manifest it except after a long time. But mostly within 3 to 21 days, the patient becoming manifesting of the disease. Recovery may take months. And we saw patients that take several months to recover from this disease. And actually, the patient who recovered in ICU from tetanus explain or clarify how good this ICU. Because these patients need every sort of support in the ICU, hemodynamic support and nutrition support and physiotherapy, and these patients need a highly specified care in the ICU. Recovery may take months. About 10% of cases prove fatal, really, it is a fatal disease if not treated accurate. Diagnosis is based on the presentations, tetanus symptoms, and doesn't depend upon isolation of bacteria. Even if you're not, because which is recovered from the wound in only 30% of patients. Not every patient you can't isolate the bacterium from. And it can be isolated from people without tetanus. Some people have harboring the organism, but in the gastrointestinal tract. There is test, very simple test really for diagnosing the tetanus. Spatula test. Just you can introduce the tongue depressor inside you as a patient and touch that. You will provoke the convulsions and the locked jaw. The ordinary response for a spatula test, if you introduce something, the patient will gag and vomit and cough and so on. But in such a situation, the patient will start to beating the spatula and you elicit the contraction of the face muscles. And even, I said to you, even the patient not waiting spatula test, the patient just you speak to him, any stimulus, just touch him, he will start contraction and severe contraction, which persists for minutes. And it is a repeated contractions, not only one time. Incubation period of tetanus may up to several months, but is usually about 10 days. And this is the rule, really. The farther the injury site is from the central nervous system, the longer the incubation period. The longer the incubation period. The farther the injury site is from the central nervous system, the longer the incubation period. The shorter the incubation period, the more severe the symptoms. Types of tetanus, there is generalized tetanus, neonatal tetanus 4 to 14 days after birth, local tetanus, and cephalic or cephalic tetanus. Both vaccination and tetanus immunoglobulin are recommended and are the only treatment for such patient, in addition to the supportive management. As I said, the patient needs supportive management for everything. The wound would be cleaned and any dead tissue must be removed. We can give metronidazole is the best. We can give diazepam. Penicillin really blamed, maybe provoke some convulsions, and so we not like it. Severe tetanus, we can inject the human tetanus immunoglobulin, inject intrathecal. You can inject it intrathecal, increase the clinical improvement from 4% to 35%. Tracheotomy and mechanical ventilation for 3 to 4 days, and caring patient on ventilation is very important. Severe tetanus also, the magnesium sulfate is very important in such situations. And I saw many patients not responding to even muscle relaxant, and we enforce it to increase our doses of muscle relaxants. The magnesium is really good, give us a dramatic response in such patients. And we give it through infusion, 1 gram, 2 grams, 3 grams, every hour for such patient. Very important in addition to benzodiazepine. As you know, benzodiazepine action is muscle relaxations, in addition to anti-anxiety, anti-apprehension, and improving the patient's situations and ameliorating some side effect of the psychological problems. Severe tetanus also, the dysautonomia is, as I said, is very problematic, and so you have to arm yourself with leptalol, beta blocker, magnesium, clonidine, nifipine, and other drugs as diazepam and muscle relaxants, very important. The other disease which I wanted to mention here, myasthenia gravis or myasthenic crisis, and in myasthenic patient, as you know, there is antibodies. As you know, there is antibody against the acetylcholine receptors post-synaptic to differentiate it from the Lambert syndrome, which is pre-synaptic block. In myasthenic syndrome, the patient becoming a feature of weakness in fatigability, ongoing effort rapidly provoke worsening weakness, strength improve with rest, fluctuation of severity over time. The patient becoming in the morning, going up in the morning, very good, well, and by time he becoming weak and he can't swallow, he can't speak, he can't smile, he can't open his eyes, dropping and so on. And so there is some sort, there is here post-tetanic fade, not post-tetanic potentiation as in Lambert syndrome. Lambert syndrome, which affects the calcium channels, affect the presynaptic, respond to electrophysiological study, there is post-tetanic potentiation. But in myasthenic crisis, post-tetanic fade, the patient exhausted by repeated stimulations. Patient exhibiting normal sensations, normal deep tender reflexes, not like Barré syndrome, normal pupillary reflexes. Only eye deviation, you see here, deviation of eye and the dropping of eyelid in a person with myasthenia gravis trying to open her eyes. Antibody accelerate degradation of acetylcholine receptors, decreasing the number of receptors on the post-synaptic membrane. Distributions, eye and the bulbar muscles tend to be affected, involved early, and only skeletal muscles are involved, not the pupils. Generalized weakness can also occur and involving diaphragm and limb after that in some patients. Diagnosis of myasthenia gravis, we can give just the anti-acetylcholine, it is anti-acetylcholine antibody, sensitivity 80%, or no detectable antibody, seronegative myasthenia could be diagnosed in some of patients not accepting the anti-acetylcholine antibody we can't find, but the diagnosis is or seronegative myasthenia gravis. Diagnosis of myasthenia gravis, also eye speck test is very important and very simple and carry a high sensitivity and high specificity value. Just you put eyes on the upper eyelid to potentiate the action of the receptors, and the patient started to strengthen the muscle, and the patient started to raise his legs and becoming improved. The other test, which is pharmacological hydrophonium, as you know, it's a short-acting anticholinesterase. You give it 2 milligram. If not effective after 1 to 2 minutes, you can increase to 8 milligram, but take care of its drawbacks. Bradycardia, some sort of cholinergic stimulation. And we have to differentiate between myasthenic crisis and cholinergic crisis. Because as you know, myasthenic patient is treated by anticholinesterases, the enzyme which distracts the acetylcholine to give chance to acetylcholine to build up at the neuromuscular junction, and so to potentiate the action at the acetylcholine receptors. If you give too much doses of acetylcholine sterase inhibitors like idrifonium, pyridostigmine, neostigmine, you will predispose your patient to another crisis, which is cholinergic crisis, which looks like organophosphate poisoning, which occur in the war, and we treat it by atropine and ralidipsime and so on, which I think you remember, most of you remember the Gulf War, and we started to arm ourselves by this item of drugs, ralidipsime and atropine, to antagonize organophosphate poison. And so there are two main problems in myasthenic patient, myasthenic crisis and cholinergic crisis. Myasthenic crisis result from the disease itself, exaggerated disease, exaggerated inhibition of the acetylcholine receptors. cholinergic crisis, exaggerated response to or excessive dose of anticholinesterase drugs like hydrophonium and pyridostigmine and histamine. Hydrophonium is a short acting, and so we diagnose with it. If it gives improvement, the patient suffering from myasthenic crisis or myasthenia, the graves. If the patient not responding, this patient not myasthenic, and we have to seek for another problems. Treatment in such a situation in myasthenic patient, we use pyridostigmine, which is a long-acting anticholinesterase and exhibiting less side effect, less cholinergic side effect than neostigmine. And it could be taken orally, and the dose from 60 to 120 milligram every day or every 12 hours, or we can increase. Every patient really need manipulation of the need titrating the dose of the anticholinesterase for him, especially after operation, especially after thymectomy. The patient may take 120 milligram per day or twice daily before the operation, before thymectomy. After thymectomy, you have to manipulate the dose requirements. Otherwise, you will introduce your patient or produce cholinergic crisis. Also, in addition, we don't forget the plasmapheresis in such patients, which is very important, especially before thymectomy. We prefer to make plasmapheresis, and also other immune suppressive therapy to decrease the total concentration of antibodies which are present.
We have 3 minutes left, Prof.
Oh, I am always unlucky, Dr. Saad. The time is tight. Really, I wanted to speak about another problems in our ICU, disease as botulism, as muscle disease itself, as Duchenne atrophy or polymyositis, or critical illness myopathy, or critical illness neuropathy, and other diseases which affect the neuromuscular unit in our ICU. But I think the time is not enough as usual. And so I have to stop at this point. And don't forget in cholinergic crisis to use glycopyrrolate or hyoscyamine because it is less in its blocking and its side effect. If the patient manifesting excessive cholinergic crisis, steroids may be used, but gradual using of steroid in myasthenia, or start by small dose, or wait till the patient exhibiting improvement and then start steroids to enhance the clearance of antibodies. Thymectomy is very essential and for myasthenic crisis, but we have to prepare the patient with pre-thymectomy plasmapheresis. Some ask if we can use high flow nasal catheter or BiPAP to myasthenic patients. We can in the early stages, but not in patient deteriorating and exhausted. We can't use BiPAP or high flow nasal catheter in exhausted patients. We can use it in early stages of myasthenic patient exhibiting some breathing difficulty, just to enhance the breathing power. But after that, we have to, if the patient deteriorates, we have to intubate and treat the patient. Decision to intubation is a clinical, as I said, clinical decision, not depend on spirometry or blood gases or vital capacity or negative expiratory pressure or forced expiratory pressure. Depend on clinical evaluation. Don't wait till patient accepting hypercapnia. This is a extremely late finding in this context. And I think enough this our talk today about Bari and also about tetanus and myasthenia. We postpone botulism and other disorders to next lecture.
Thank you, Prof. We'll go to Barbara because we have no time, and great pleasure to have you, Prof, tonight. Barbara, all yours now.
Thank you for that wonderful lecture, Professor. It's wonderful. I think we have a couple questions for you. Here is the first question. Let me see. It says, Professor, you have mentioned that the rate of plasma exchange would be 200 to 250 milliliters per kilogram for 5 sessions. Is that right?
Yes, over 5. In which disease? In which disease? We always use it in 5 sessions. Some using it for 6 sessions or 7 sessions. But the research work proving, or the most of the trials, no difference between 6 and 5 sessions or more sessions. 5 is enough.
Okay, thank you. There's a second question. It says, Professor, is there any specific nutritional support in muscle weakness syndrome?
Really, these are good questions. In a patient with muscle disease, they need more protein requirement, more protein content, more vitamins like vitamin B1, B12, folic acid. They need some trace element. Also, high calorie diet. They need more calorie diet because the catabolism here in the muscle disease is very high. So they may need, the adult may need 3,000, 3,500 kilocalorie per day.
Thank you. Those are the 2 questions that are in the log right now. So unless someone has another question, type in real quick. We will go to our next lecturer.
If you don't mind, we can go straight to Prof. Makarita presentation because we are running out of time.
We're running late. Okay. So our next professor is Dr. Mohammed Makarita, who is going to educate us on prevention and management of post-herpetic neuralgia. Thank you, Professor.
Thanks, Barbara, for your introduction. My talk today about prevention and management of post-herpetic neuralgia. I have no cause for disclosure. This lecture, based on our experience in Egypt, documented by a series of publications in high-ranked, respectable pain journals. First, I will discuss a case scenario. 75 years old diabetic male patient presented to ENT department with severe pain in the left side of the face, especially at the region of the left ear. For 4 days, patient was admitted and diagnosed as severe otitis media. Patient received intravenous antibiotic and analgesic. 3 days later, vesicle appeared over the left side of the face and the left ear, and the diagnosis of acute herpes zoster was confirmed. Intravenous acyclovir was added, and patient complained of intolerable facial pain and inability to sleep. Therefore, they asked for a consultation from our pain unit. This is our patient. Notice his old age, and notice the vesicle over the ear and the face. This is Ramsay-Hunt syndrome, which is affection of geniculate ganglia of the 7th cranial nerve. It may be followed by post-herpetic neuralgia, facial palsy, and hearing loss. So it is a disastrous condition. Another case scenario, 77 years old female patient referred to our clinic from OPD, from the neurology department, with intolerable left supraorbital pain and inability to sleep. History of left ophthalmic branch herpes zoster infection 3 months ago. Family members were present with her in OPD and were anxious about the case. This is our lady, old age female with supraorbital with ophthalmic branch herpes zoster followed by post-herpetic neuralgia. Notice the scarring over the supraorbital nerve and over the left forehead. Now my question, is there any difference between the 2 cases in the management? This is the result of our discussion today. Therefore, the objectives of our talk, first, to review the pathophysiology of post-herpetic neuralgia, discuss the evidence for post-herpetic neuralgia prevention and the treatment of post-herpetic neuralgia either by medical therapy or intervention pain therapy. Varicella zoster virus is the causative agent for chickenpox in children and herpes zoster in adults. During the primary infection, the virus go through the nerve from the skin to be dormant in the dorsal root ganglion. Then, if cell-mediated immunity depressed, the virus will go to the other direction to the skin, causing herpes zoster eruption. If viral reactivation occurs, the virus travels along the peripheral nerve to the nerve ending, producing pain and skin lesion. Viral reactivation causes ganglionitis and neuritis, causing pain along the segmental distribution of the nerve. Clinical diagnosis of herpes zoster is made once rash appears. Before the rash appearance, there is a dilemma of differential diagnosis. 50% of herpes zoster are thoracic. The commonest is dorsal 5 and 6. 20 are trigeminal. 20 are cervical. And 10 are lumbosacral. Clinical presentation of acute herpes zoster, general symptoms in the form of fever and fatigue, but herpes zoster pain is unique. It is unilateral, shooting, stabbing, band-like dysesthesia, hyperalgesia, and allodynia. Pain precedes skin eruption by 5 to 7 days, and severity of the skin lesion, pain, and pain duration were exaggerated with the increase of age. Usually pain, hyperalgesia gradually decrease, and healing occur in 4 to 6 weeks. In some, pain persists, producing what is known as post-herpetic neuralgia. This is one of the most important slides in my presentation. Risk factor for acute herpes zoster. First, age. Old age are high risk group. Malignancies, especially lymphoma, immune suppressive drug, chemotherapy, radiotherapy, and steroid, malnutrition, diabetes, HIV, and chronic debilitating disease like TB and renal failure. This is the risk factor for development of acute herpes zoster. But what are the predictors to develop post-herpetic neuralgia? Transmission of acute herpes zoster to a post-herpetic neuralgia. You can predict which patient will develop post-herpetic neuralgia. In addition to the previous factor, age is the most important factor for development of post-herpetic neuralgia. There is threefold increase in the incidence of post-herpetic neuralgia by the age of 70. Severity of the acute herpes zoster pain. The more severe the pain, the more likely to develop post-herpetic neuralgia, because this means severe ganglionitis and neuritis in the affected nerve. Density of eruption. The more dense, the more likely to develop post-herpetic neuralgia. Ophthalmic branch per se or trigeminal herpes zoster is one of the character of post-herpetic, is likely to develop post-herpetic neuralgia. Even in young age, patient did not receive appropriate antiviral therapy because the antiviral therapy has a protective character. Remember the predictor for post-herpetic neuralgia, please. This is a case of post-herpetic neuralgia. Notice the pigmentation, and this is associated with allodynia and pain in this pigmented area. Post-herpetic neuralgia, either self-limiting disease, mild, or severe constantly burning dynamic allodynia with skin pigmentation. Post-herpetic neuralgia affects the quality of life. Many patients develop severe physical, occupational, psychological, and social disabilities. Therefore, it is desired to avoid this disastrous sequelae toward a more benign self-limiting disease. What is the pathophysiology of post-herpetic neuralgia? This is the nerve, and this is the endoneural artery, and viral inflammation induces profound sympathetic stimulation, causing the vasoconstriction in the endoneural artery, reducing ischemia and reduce blood flow and in the intraneural capillary bed. If ischemia persists, endoneural edema forms in this area and increase endoneural pressure, more ischemia will result. Further decrease in the oxygen, nutrition of the nerve and blood flow, and producing irreversible nerve damage and scarring. So the whole picture is vasospasm of the endoneural blood vessel. This damage will destroy the large myelinated E beta fiber, which are metabolically more active, and spare the small fiber responsible for pain, which is the C fiber. Therefore, there is loss of the gate control and loss of the inhibitory control over the incoming pain signals. Therefore, pain become continuous and more severe. Complications of acute herpes zoster include pneumonia, encephalitis, facial palsy, herpes zoster ophthalmitis, including ulcer, iritis, and keratitis. Secondary infection, post-herpetic neuralgia is the most common complication of post-herpetic neuralgia, of acute herpes zoster. This is a case of lymphoma suffering from secondary infection. She suffered from acute herpes zoster and secondary infection, septicemia, and end by this. This is keratitis. It's a shame in 21st century to find a patient like this. And this is a facial palsy associated with Ramsay-Hunt syndrome or facial palsy associated with facial herpes zoster. Misdiagnosis of pre-eruptive stage of acute herpes zoster. Before eruption, you can't diagnose acute herpes zoster. You can suggest only acute herpes zoster if the pain is dermatomal. Myocardial infarction is one of the misdiagnoses, cholecystitis, appendicitis, and glaucoma. Now, management of herpes zoster. What is the aim of our management for a case for acute herpes zoster, like the first case scenario? To relieve pain and reduce its severity? Yes. Reduce duration of the attack and reduce the patient suffering? Yes. Reduce the duration of eruption? Yes. Prevent the complication. This is the most important target of our strategy. Management of already presented cases with post-herpetic neuralgia. Prevention of post-herpetic neuralgia is easy, but treatment of post-herpetic neuralgia is a challenge, and the result is disappointing. So I believe that one action can make a huge difference. Therefore, our mission is to increase the awareness about the new strategy for prevention of post-herpetic neuralgia named the 10-step model for prevention of post-herpetic neuralgia. What is our strategy for prevention of post-herpetic neuralgia based on evidence-based medicine? We can use varicella zoster vaccine, systemic antiviral therapy, medication like antidepressant, anticonvulsant, opioid, and systemic corticosteroid. Sympathetic blockade for prevention of post-herpetic neuralgia can be also used. Varicella zoster vaccine is given during the childhood period in developed countries, and this decreases the incidence of chickenpox with subsequent reduction in the incidence of acute herpes zoster and its reactivation, and therefore there is account for reduction in the incidence of post-herpetic neuralgia. There is reduce the incidence of acute herpes zoster by 51% and the risk of post-herpetic neuralgia by 66%. And it is approved by FDA in 2006. So we can use vaccination for children and booster dose for other all elderly patients which has susceptible for development of acute herpes zoster, like immune-compromised patient on steroid or chemotherapy, radiotherapy, and elderly per se. Antiviral therapy. Topical antiviral therapy is not effective, but systemic antiviral therapy is effective. We can use acyclovir, valacyclovir, famaciclovir, and the duration of treatment is extended from 7 days up to 10 days if there is new eruption. Acyclovir per se must started in the first 3 days of eruption, and the dose is 800 milligram 5 times per day. The usage of appropriate antiviral therapy was associated with 50% reduction in the incidence of post-herpetic neuralgia at 6 months. This is a great achievement. Antidepressant, amitriptyline. There is only single study discussing the value of amitriptyline in preventing of post-herpetic neuralgia in 1997, and it is old study and not reproducible, not replicated, and this is the weakness in this study. To myself, I didn't believe that amitriptyline early can prevent post-herpetic neuralgia. Even I did not use amitriptyline for my patient because my patient is old, can be suffering from comorbidities like advanced cardiac condition, senile prostate hyperplasia, or glaucoma. The three are absolute contraindication for use of amitriptyline. So the use of amitriptyline on old age is questionable and need no comorbidities like cardiac condition. So in this randomized double-blind study, it is single study, but it is randomized double-blind study, so it appears in the evidence. Anticonvulsant like gabapentin and pregabalin can be used as adjuvant with sympathetic blockade. They may be useful in relieving persistent paresthesia, dysesthesia, and allodynia. But remember that it has no value in prevention of post-herpetic neuralgia. It can alleviate pain, decrease pain in conjunction with the sympathetic blockade, but it has no value in prevention of post-herpetic neuralgia. Opioid is the mainstay for short-term treatment of severe pain. There must be a clear understanding that opioids are to be used for a limited term in case of severe non-cancer pain. For, Barbara, the opioid stigma in Europe and in United States. This is because of the use of high doses of opioid for non-cancer patients. For acute disaster, tramadol and oxycodone can be used, and it is suitable anti-neuropathic medication. Systemic corticosteroid. A Cochrane review in 2010 found no significant difference between systemic corticosteroid and placebo in preventing post-herpetic neuralgia. However, this combination improves acute herpes zoster pain, patient quality of life compared to acyclovir alone. This allows quicker return to the work and improve the sleep better. So systemic steroid has no preventive effect on post-herpetic neuralgia, but systemic steroid improves the symptoms. This is for systemic, oral or intravenous. What about sympathetic blockade for prevention of post-herpetic neuralgia? Several study demonstration of inclusion of steroid with local anesthetic in the neuroaxial blockade for management of acute herpes zoster and post-herpetic neuralgia prevention. This is 4 studies. 3 of them are randomized clinical trial, and 1 is non-randomized clinical trial. What is the evidence from this study? By the year of 2011, the evidence in the evidence-based book in chapter 17, one-time epidural injection to be negative. Remember, it is one-time epidural injection to be negative, no effect. Repeated paravertebral and sympathetic nerve block to see positive. This is because of the opacity and few number of the studies. However, in the light of recently available randomized placebo clinical trials, the evidence must be reviewed. Recent studies include effect of early-stage ganglion block on the facial herpes zoster and the prevention of post-herpetic neuralgia. This is from Egyptian team from Tanta and Mansoura University by my colleague Yasser Amr and Yusuf Bayoumi and me. This is stellate ganglion block, and this is our patient suffering from Ramsay-Hunt syndrome. After certain days, there is improvement of his pain, no sequelae like post-herpetic neuralgia, or no facial palsy or hearing loss. This is a great achieve. This is the paper, and the incidence of post-herpetic neuralgia in the active group was significant after 3 months and 6 months, and the duration of pain also significantly reduced. For thoracic herpes zoster, the same team published another paper in the pain practice, which is big known journal, single paravertebral injection for acute thoracic herpes zoster. This is a single injection. This is a paravertebral space and contains somatic intercostal nerve and sympathetic fiber. So it is a sympathetic blockade, and the block can extend to the epidural space, producing epidural blockade in 70% of our patients. This is paravertebral block. This is very nice, showing the epidural spread. And this is one of our patients. And after about 3 weeks, there is improvement in pain. And the result of this study was that after 3 months, there is non-significant reduction in the incidence of post-herpetic neuralgia. Notice 15 versus 8, but it is not significant. After 6 months, there is significant improvement in the incidence of post-herpetic neuralgia. The duration of pain and the duration of eruption also improve in this study. In 2017, a systematic review and a meta-analysis found that this include about 800 paper, but only select 9 paper because of the inclusion criteria and avoid the bias in this study. So they reviewed a big number of paper, but included a small number of paper. And these 9 studies include our randomized clinical trial from Egypt. And also, these studies contain the least biased in its methodology. And the result is early sympathetic blockade can decrease the incidence of post-herpetic neuralgia significantly. Notice the diamond. After 6 months, also there is significant decrease in the incidence of post-herpetic neuralgia, and after 1 year. The conclusion of this study, early supplement therapy can significantly reduce the incidence of post-herpetic neuralgia. Supplement means that the drugs like gabapentin, pregabalin, amitriptyline, and TENS, in addition to the intervention. But subgroup analysis, they found that early systemic adjuvant like gabapentin, pregabalin, amitriptyline, and TENS has no significantly reduced the incidence of post-herpetic neuralgia. But early supplement intervention procedures has a beneficial effect on preventing of post-herpetic neuralgia with a high p-value. They concluded that every use of intervention procedure for acute pain from acute herpes zoster may be preferred choice for patient without contraindication, but the evidence is moderate. More data from high quality randomized clinical trial will be needed to confirm the result. This is in 2017. So the intervention pain therapy has a great role in prevention of post-herpetic neuralgia. In another paper, we wanted to put a strategy for prevention of post-herpetic neuralgia known as the 10-step model for prevention of post-herpetic neuralgia, published in Pain Physician in 2017, and is a 10-step model formed from 10 steps. First, awareness of the population and education of the healthcare providers about the nature of herpes zoster infection and its complication. Vaccination for children and the high-risk group. Early diagnosis of acute herpes zoster. Early use of antiviral therapy in optimal dose and optimal duration. Identification of risk factor for the development of post-herpetic neuralgia. As I mentioned, the age is most important factor. Stratification of acute herpes zoster into one of three groups. This is very important slide. Notice that if your patient is below 50 without risk factor, not diabetic, not immune compromised, not renal failure, no bone marrow transplantation, you can give antivirus therapy and symptomatic pain therapy without sympathetic blockade. But if your patient is below 50 and with one or more of the risk factor, diabetic, immune compromised, this patient will shift and deal with as if it is above 50. And the strategy will be antiviral therapy, symptomatic pain therapy, plus repeated sympathetic blockade. And sympathetic blockade can be used according to the region. Head and neck, stellate ganglion block. Truncal, paravertebral block, epidural, and thoracic sympathectomy. Lumbosacral, caudal epidural, lumbar epidural, or lumbar sympathetic blockade. This is repeated injection, at least 2 block, or continuous blockade for 2 weeks. This is our strategy. Optimization of symptomatic pain therapy, including anti-neuropathic drug, antidepressant, anticonvulsant, and opioid and tramadol, and follow-up of the patient and the detection of complication like keratitis, and good reporting, filing, collection of the data, and analysis of the data. From the 7th step, you can notice that the number and the frequency of blockade did not clarify it. I said that repeated injection at least to 5. Therefore, we conduct a new study accepted in the pain physician in 2020 in May, the effect of repeated paravertebral injection with local anesthetic and steroid in prevention of post-herpetic neuralgia by Dr. Yasser Amr from Tanta and me from Mansoura University. And from this study, we can find that 2 and 3 have equal result, but in patients with multiple comorbidities and risk factor, we prefer 3 injections rather than 2. Therefore, the golden rules in acute herpes zoster management, the earlier the treatment, the less likely to develop post-herpetic neuralgia. I mean, the injection must be done in first week of after eruption to avoid vasospasm and scarring of the nerve. In high-risk group, early aggressive treatment is mandatory. Treatment of post-herpetic neuralgia. Treatment aim in post-herpetic neuralgia is just to relieve pain and reduce its severity and improve the quality of life. It is almost a palliative to improve the quality of life. There is no cure from post-herpetic neuralgia. In some mild cases, there is spontaneous resolution of the case, but it is not the rule, especially in our community in Egypt and third world where there is no vaccination. Because vaccination, the attenuated virus cannot be reproduced and produce severe acute herpes zoster. But in our countries, there is no vaccination. So it is a wild virus producing acute herpes zoster followed by severe post-herpetic neuralgia. Treatment modalities for post-herpetic neuralgia includes symptomatic pain therapy and intervention pain therapy. This is the New England Journal treatment of post-herpetic neuralgia. This is a treatment modality, and this is the number needed to be treated, and the lidocaine batch 2, and it is approved by FDA, capsaicin batch 3.3, and it is approved, not approved by FDA, gabapentin and pregabalin, also approved by FDA, by Take Care for the serum creatinine, because these drugs are 100% secreted by kidney. Take Care for serum creatinine, tricyclic antidepressant, it is off-label use. And remember the contraindication of amitriptyline, which is glaucoma, senile prostate hyperplasia, and advanced cardiac condition, because the amitriptyline can increase the silent deaths by 20 to 25% in advanced cardiac diseases. Morphine, oxycodone, and tramadol. Remember the risk of abuse, and remember that tramadol associated with amitriptyline in high dose may induce serotonin-like syndrome. This is the evidence for intervention. Acupuncture is not effective. Sympathetic blockade in already presented cases of post-herpetic neuralgia is not effective and better to be avoided. Intrathecal methylprednisolone is not effective, and please avoid it. Can produce fungal meningitis and arachidonitis. Excision of the skin, it is not effective. Botulinum toxin can be used in refractory cases, and it is effective, but the duration is from 3 to 6 months. Spinal cord stimulation, there is only prospective case series, and it is effective in developed country and found to be effective, but its efficacy decreases with time. Deep brain stimulation, also it is inconclusive. Pulsed radio frequency for dorsal root ganglion and intercostal nerve for thoracic post-herpetic neuralgia is functioning, but also it has a limited duration, about 1 year. This is a study, randomized clinical trial for pulsed radio frequency. Notice he used tramadol in addition to pulsed radio frequency from the start when was above 6 or 7 for severe pain. Therefore, the pain did not come below 3. In 2018, we published the ultrasound pulsed radio frequency in management of thoracic post-herpetic neuralgia. But the trick here is first we give 2 weeks of pregabalin, 300 milligram per day. This will decrease the central sensitization and bring the pain from severe to moderate, from 7 to 5. And then we did the radio frequency, pulsed radio frequency for intercostal nerve. And this associated with reduction in the pain for about 6 months below 3 on VAS, below 30. This is a great achievement rather than the other paper from China. They started early and found the result is not good. And ultrasound guided the conclusion, BRF for intercostal nerve in combination with pharmacotherapy in management of thoracic post-herpetic neuralgia is promising treatment modality. It provides effective post-herpetic pain control, less analgesic consumption, and significantly improved the quality of life of our patient. Recent review in 2019, this is intervention treatment for post-herpetic neuralgia, the evidence in the pain physician, and the result found that we can use botulinum toxins, triamcinolone subcutaneous, transcutaneous electrical nerve stimulation, peripheral nerve stimulation, paravertebral block, stellate ganglion block are recommended first, followed by pulsed RF. I agree, because of the cost, the price. If pain persists, we can use spinal cord stimulation. And they avoid the use of intrathecal methylprednisolone because it is dangerous and the level is 2. We need more randomized clinical trial. In 2020, in the pain physician, a study from China found that spinal cord stimulation and pulsed RF for dorsal root ganglia both are effective. Remember that it has a duration of effect, not continuous effect. The effect of spinal cord stimulation, it is a spinal cord stimulation is costly procedure, and many complications like infection, migration of the plate, and like this, and decrease its efficacy can occur. And pulsed RF has a limited duration, about 6 to 1 year. At the end of my lecture, please remember that prevention is better than treatment of post-herpetic neuralgia. The 10-step model is effective tool for prevention of post-herpetic neuralgia. The earlier the treatment, the less likely to develop post-herpetic neuralgia. In high-risk group, early aggressive treatment is mandatory. Treatment of post-herpetic neuralgia, it is palliative. Thank you.
Barbara, all yours now. Is Barbara here? Barbara, can you start your Prof. Macharita, thank you much for that distinguished presentation and lecture. Barbara?
Yes, hello. I believe we have some questions for you,
Yes,
Dr.
welcome, Roberto.
Machariti. So let me find the questions here.
Yes.
Here is one. It says, Professor, do you have any experience with ultrasound guided ESPB for thoracic post-herpetic neuralgia?
Ultrasound what?
It says ultrasound guided ESPB for thoracic post-herpetic neuralgia.
This is erectrospiny? Block?
I'm just reading the question. ESPB.
Ultrasound pulsed wave radio frequency.
No, it is erectrospiny brain block.
Yes. This is erectrospiny. Oh, remember that if you wanted to block erectrospiny, it is indirect paravertebral block. Erectrospiny is facial plane and associated with paravertebral block. The target of our block in post-herpetic neuralgia is to examine the response of the nerve for the local anesthetic. If there is a result, this means that it is still a viable nerve, because post-herpetic neuralgia has some incidence of deafferentation pain. If the pain is not improved with the block local anesthetic, this means that high incidence of deafferentation pain, and there is no result of pulsed radio frequency in patient with deafferentation. It needs spinal cord stimulation. So the facial plan block can attenuate the pain or per se, can attenuate the pain of post-herpetic neuralgia, and can be combined with high doses of pregabalin, like pregabalin 300 milligram per day. So it is also a combination therapy.
Thank you. There is another question for you, Professor. What is the role of opioids, and when should you use opioids for post-herpetic neuralgia?
Yes. The international policy found that opioid is the second step as anti-neuropathic drugs. So we need to use a drug with the ability to bring a result with neuropathic drug. Which drug? If it is pure mu agonist, we need high doses. But for tramadol and oxycodone, tramadol works by different mechanisms, like activation of the descending inhibitory pathway, modulation of the NMDA receptor. This sodium channel block. These mechanisms are effective in post-herpetic neuralgia. While the oxycodone works by its kappa effect. So if it is pure mu agonist, we need high dose of opioid, and this is carry a high risk of abuse. We should use opioid for a limited duration to avoid the abuse of opioid, especially in non-cancer patients.
Wonderful. Do we have time for one more question, Dr. Mahdi?
Yes, yeah, you can.
Okay.
Thank you.
So here's one more question for you, Professor.
Okay.
It says, how long should we use gabapentin for post-herpetic neuralgia?
Yes. Provided that your patient has normal kidney function. My advice to start 150 twice per day, high doses to attenuate central sensitization and to build a trust between you and your patient. This 150 twice per day associated with 30% reduction of his pain. This is documented in the paper. So 300 per day associated with 30% of his pain. And this, after 2 weeks, you can do pulsed radio frequency, as I did in my publication. So don't start by wild horse. Don't try to catch him. Give some sweetie sedation, then catch him. This is the same idea.
Wonderful, wonderful. Looks like there's one more that's popped up here, Professor. What is the mechanism that stellate ganglion blocks prevent the post-herpetic neuralgia?
Again, remember the evidence. The effect of sympathetic blockade is not conclusive for treatment of post-herpetic neuralgia. Sympathetic blockade for acute herpes zoster to break the cycle of vasospasm of the interneural blood pressure, of the interneural blood vessels, and to increase the oxygen and nutrition to the nerve to avoid the scarring of the nerve. But in post-herpetic neuralgia, if you put the definition of post-herpetic neuralgia 3 months after the incidence of acute herpes zoster, then there is no role for sympathetic blockade. If you put it as 1 month, please try sympathetic blockade, because in some of my patients, it brings a result. So the gray zone is between 1 month and 3 months. Do you know the definition of post-herpetic neuralgia in some books 1 month, and in another books 3 months. For myself, I consider the post-herpetic neuralgia after 3 months. So after 3 months, no role for sympathetic blockade. After 1 month, there is a role in the gray area to use sympathetic blockade.
Wonderful. Thank you so much. I think that's all the questions that have popped up.
Barbara, remember that this is my experience and my colleague in Egypt, and this is documented in our publications.
Wonderful. Thank you so much. Wonderful lecture, Professor.
Thank you.
So next professor who will educate us is Dr. Rhonda Badawi, Professor of Anesthesia, and you are going to educate us on heparin-induced thrombocytopenia, also known as HIT. Thank you, Professor.
Before we start, we have a surprise for Professor Randa Badawi. So one of your excellent colleagues want to say hello to you.
Hi, Randudi, how are you? I miss you so much, lovely. Hi, Habibti.
Thank you very much.
Nice to see you and to hear you again.
Thank you very much.
Miss you. Come back soon.
Thank you very much, Prof. Sahar Marzouk is here us to honor us today.
Yeah.
And thank you very much. Welcome, Professor.
If you excuse me, Dr. Saad, I want to add some points. Okay. Sorry to all because I wasn't available at the beginning of this course, but I would like to thank so much Dr. Ansari for his valuable, illustrative, informative lectures. I used to listen because I'm so interested in critical care. So thank you so much, Dr. Ansari, and thank you to Dr. Makharita also, though pain is not my interest, but I can know that it is very interesting lectures he used to give every time. Also, Dr. Saad, really what you are doing is very, very, very precious courses, because all the instructors and the lecturers are highly educated and of high faculties. So thank you so much for this effort, and keep on, and waiting also to hear a lot of lectures from your colleagues. Thank you.
Thank you, Prof. Sahar. Thank you for coming tonight, and all the best, Prof. Randa. It's all yours now. Thank you. You can start sharing your screen, please.
Okay.
You're right.
Okay.
Yeah, we need to share your screen, please.
Okay. Okay. 1 minute, please.
Thank you.
You're welcome. Is it clear?
It's clear, but slide. Yeah, that's perfect. Thank you.
Okay, you're welcome. First of all, I'd like to say good evening to everyone. Really, I'm honored to be with you today, and I'd like to thank Dr. Saad Al Mahdi and all the organizer committee for their great effort and hard work. Today, I'm going to discuss a very important subject for all the anesthetists, especially those working in the ICU. My topic is heparin-induced thrombocytopenia, and it's related to the nowadays events, COVID, since part of its treatment concern anticoagulants. So I found it's perfect to discuss these items. By this lecture, I'll discuss what's meant by its types, pathophysiology, risk factors for its development, clinical presentation, and lastly, treatment. I'm going to start with a scenario, and if every one of you try to pick up the correct answer and write it down, and in the end of the lecture, we will discuss it, and you can see how much you know about anticoagulants and this subject. My scenario is a 62 years old male with a history of diabetes mellitus, hypertension, coronary heart disease, is admitted to hospital for unstable angina. He was recently diagnosed with HIT type 2, as now scheduled for 3-vessel cabbage. The suitable agent for intraoperative anticoagulation would be heparin, clopidogrel, ergotropan, or fondaparinol. Think of it, and we will discuss it in the end of the lecture. I'd like to give a brief, quick review of physiology of coagulation. Coagulation process aims for hemostasis. It starts after vessel injury by vascular injury by vasoconstriction of the vessel wall. This is mediated by thromboxane A2. Then activation of the platelets through its binding to subcollagen endothelium. The activated platelets release its mediators from its platelet granules, which amplify further platelet aggregation and adhesion. This is called a step of platelet activation aggregation. Then platelets share with coagulation factors, ending by the formation of the clot. The main component of the clot is thrombin. As we will see in details, the coagulation cascade is divided into, for simplicity for sure, into intrinsic pathway and extrinsic pathway. By intrinsic pathway, we mean that activation could be from inside the body or within the blood. And this pathway can occur both in vivo and vitro. While the extrinsic pathway, the stimulus for its occurrence is the release of tissue factor. So it's only a vivo process. For the intrinsic pathway, it begins with activation of factor 12. It can be, the stimulus for its activation is negative charge through exposure to subendothelial collagen in vivo, or exposure to negative charge of a glass in the test tube in vitro. This is how it will start the cascade. Factor 12, it will be activated into 12. Then active 12 will activate factor 11 into active 11. Active 11 will stimulate factor 9 into active 9. Then factor 9, through the activated factor 8 will activate this part, which is the common pathway. This is the intrinsic pathway. The extrinsic pathway starts by tissue trauma, which release thromboplastin. It's a tissue factor, and it's number 3 of the anticoagulants. Factor 3 activates factor 7 into active 7. Active 7 acts on the factor 10. This is the common pathway. So the intrinsic pathway and extrinsic pathway all together ends on the common pathway. The common pathway starts with activation of factor 10 into active 10 through in the presence of active factor 8, the presence of factor 5, presence of calcium, and presence of platelets. So is the link between the coagulation cascade and platelet plug or platelet activation. Then activated factor 10 will stimulate prothrombin. This is factor 2 into active factor 2. Thrombin activates fibrinogen, which is factor 1, into fibrin monomer. Then thrombin activated factor 2, which is thrombin, activates factor 13, which changes the fibrin monomer into polymer by the action of factor 13. Okay. Let's concentrate, please, with the action of thrombin. It's the main stem or backbone of coagulation is the thrombin. Why? Here is its action. Number 1, it amplifies what's before and it activates what's after. So it activates fibrinogen into fibrin. This is number 1. Then it activates factor 13. This is number 2. In the meantime, it activates factor 5 into active. Factor 5 will be activated into active 5, and active 5, it will stimulate the thrombin formation. So the cycle will perpetuate and amplify. So it's called an amplification step action of thrombin. Also, thrombin activates factor 8, which acts on factor 9 to activate factor to activate factor 10. Here's the action of coagulation for forming the clot. In the meanwhile, I don't want the clot to spread everywhere. So in the meantime, the fibrinolytic system will take action. So the one who started the problem, it will end it. So thrombin will activate what's called thrombomodulin. Thrombomodulin is the complex which binds to thrombin. So after being a very potent coagulating factor, thrombin, when it combines to thrombomodulin, it modulates its action, it becomes ineffective. This complex, TT complex, thrombomodulin complex, will activate protein C, which is a natural anticoagulant in our body. And this complex, thrombomodulin complex, where after activating the protein C, will inhibit both factor 5 and 8, which were part of the stimulation in the cascade. So by this way, the coagulation process is not perpetuating forever. It's limited to the site of the trauma, while other activated clot factors will get, the body will get rid from it by this mechanism, by limiting further propagation of the process. And in the meantime, the excess activated clotting factor will be sent into the liver to inactivate it. So to know why I said the coagulation cascade, to imagine where the anticoagulant works and what are the investigations we should ask properly when we face a patient taking anticoagulant drugs. For the intrinsic pathway, we monitor by activated partial thromboplastin time. For the extrinsic pathway, we monitor by PT, prothrombin time, and INR, which is the patient ratio divided by the normal value. This is for the how to check, how to choose the proper investigations whenever you are going to assess a patient. Then let's put the action on the graph. Our subject is heparin-induced thrombocytopenia. So heparin acts through what's called antithrombin trio. We discussed it a few minutes ago. So it acts mainly on activated factor 10 and activated factor 2, thrombin. From its name, antithrombin, definitely it will affect the thrombin. However, there is a great difference between the action of unfractionated heparin and low molecular weight heparin. Unfractionated heparin inhibits the activated factor 10, while the low molecular weight heparin, they activate factor 10 and cannot suppress the thrombin. And we will discuss why few minutes later. This is the site of action of heparin. The new drugs of the new oral anticoagulants are classified into drugs which has an anti-factor 10 activity and antithrombin drugs. So this is the cascade, and you can imagine where the anticoagulants work. Here, in the antithrombin, herodine and liporidine are examples for the direct antithrombin. Why the low molecular weight heparin cannot suppress properly thrombin? As you know, the heparin molecule is formed of many amino acids. In the unfractionated, the length is very tall, while in the low molecular weight, the length is short. To block the activated thrombin, the heparin molecule should attach to both the antithrombin and the activated thrombin. So it should be of a long chain. So unfractionated heparin is formed of a long chain, so it will inhibit. On the other hand, the low molecular weight heparin, the chain is shorter. More than 50% of the compound is of short length, so it will not cover both the antithrombin and thrombin, so it will suppress thrombin to a limited ratio. This is the explanation why there is a difference in the action between the two drugs. Okay, this is a brief on the heparin. For clinical purpose, any when we compare the difference between heparin and low molecular weight heparin, the low molecular weight heparin offers better big advantages as it is long acting. So it can be given twice or once as the protocol of treatment. It has a good bioavailability, so it has a good predictive effect. It has minimal resistance to heparin. It has a lower incidence of HIT, a lower incidence of bleeding. So it's very good. And it has a lower incidence also for HIT. However, the clinical papers say that we don't need lab monitoring for low molecular weight heparin. I want to stress on a point. We don't monitor the coagulation. By this lab monitoring, it's they mean the coagulation. So I don't need to check the APT-T, for example. But for the clinical purpose, I have to monitor platelet count thoroughly, especially if the patient is exposed to heparin for more than 5 days in order to pick up the problem, which is really very serious, and it can be life-threatening and limb-threatening, as we will know. So we will discuss HIT. HIT means heparin-induced thrombocytopenia. Thrombocytopenia means decrease in the platelet count, so the definition is very clear. This is reduction in the platelet count after exposure to heparin. This is the definition. HIT, heparin-induced thrombocytopenia, is divided into two major categories. Type 1, which is called HAT, which is heparin-associated thrombocytopenia. Type 2 is HIT. Type 2, it's heparin-induced thrombocytopenia. Take care. HAT means associated. HIT means heparin-induced. Now, the problem comes with the HIT type 2. HIT type 1 had, it's a moderate disease. It's reversible even without treatment. So whenever a patient is receiving heparin, after 2 days, the platelet count may show slight decrease. And this occurs in a large percentage of patients. 1/5 of the patient, 10 to 20% of the patient will suffer from HAT. However, because it's not immune and it's moderate and it will reverse spontaneously, there is no problems. And thanks to God, although it's a big percentage, but it's a mild complication. Thanks to God again, HIT type 2 is a severe form because it's an autoimmune mediated. It develops after 5 to 10 days, and the patient here shows severe thrombocytopenia. It occurs, thanks to God, in 1 to 3% of the patients. So, in HIT, what's the platelet count might be? The platelet count might decrease up to 30 to 50% reduction in the number of the platelets. The average will be around 60,000. It will never go down below 20,000. These are classic features of HIT. To revise it again, the platelet count will start to decrease after 5 to 10 days. The reduction will be in the range of 30 to 50% reduction. The average count of the platelets in the range of 60,000, never below 20. Why this occurs? There is activation of the platelets, and we knew from the physiology, activation of the platelets release ADP. ADP is the glue for the platelets. So they start to stick together, making what's called a platelet plug. So the platelet will be consumed. Activation of the platelets, it will not stay platelet per se. It will activate the coagulation cascade. As you know, platelets play a role in the coagulation cascade. So we discussed first the physiology. Now, the pathology is there are a lot formation of platelet plug, white clots. This is formed of heparin, of platelets. Then there are thrombi, which is formed of platelet plus coagulation factors. As a result of consumption of these platelets, the platelet count will go down, and this is the cause of the thrombocytopenia the patient complains of. The thrombotic event is very high. Its incidence is 30 to 80%. So the golden rule in any ICU patient, CBC should be followed if treatment with heparin lasts for more than 5 days. Please, this is a crucial information. Whenever you treat a patient, whether with unfractionated or low molecular weight heparin for more than 5 days, not only treatment, even flush. The patient may be in the ICU, and for flush for the central line or the arterial line, we use even the small dose of heparin may precipitate, as it is immune-based reaction. Here's a quick revision between the two types. Type 1 HAT and type 2 HIT. 1 is mild form, 2 is severe form. Incidence, thanks to God, in order not to forget, the mild is the more occurring. So its incidence is 10 to 20%, while the severe form is only 1 to 3%, thanks to God. Timing in the mild form, in type 1, it occurs after 2 to 3 days only, while the other one, classically, it occurs after 5 to 10 days. The lowest decrease in the platelet count in the first type 1, is 100,000, while the other type, it's mainly in the range of 60, never below 20. This is the lowest figure. Antibody mediated for type 1, no. For type 2, yes, it's IgG related. For the thromboembolic sequelae, it doesn't occur in type 1, but it occurs in type 2, 30 to 80%. So treatment for it will differ greatly, because the first one is mild, non-immune, self-limited, spontaneous remission. It needs no treatment, only observe your patient, the observation by the platelet count and clinical. While the other type, it's very, it has a very aggressive course, as mortality and morbidity increase by 6% per day. Can you imagine how aggressive this complication? So I have to, whenever I discover a patient with HIT, I had to stop it and withdraw it immediately. But the patient needs still needs anticoagulation. So I have to shift to another anticoagulant because the pathology, there is activation of the platelets. I have to add antiplatelet drugs. Lastly, I might try plasmapheresis because it's autoimmune related disease or complication leading to the formation of a lot of antibodies of the IgG group. This is the part of the physiology. Here's the platelet. It's oval in shape normally. It contains granules, alpha and dense granules, which contains the factors which, when released, stimulate coagulation. One of these factors is platelet factor 4. Platelet factor 4, in the presence of heparin, act as a hapten. It stimulates the formation of antibodies. So antibodies will be formed by the beta cells. Then the antibodies will combine with the complex platelet factor and heparin, so that the three come together. Who are the three? Platelet factor with heparin and the antibody against the complex. These, the three will affect the platelets, causing its activation. As you see from the diagram, activation of the platelets leads to change in its shape. It becomes swollen. It starts to release its mediators, which stimulate the coagulation cascade. This is the pathophysiology. This complex, it attaches both to the platelets and to the endothelial surface of the blood vessels. The end result is activation of the platelets, which stimulate the coagulation cascade, ending by thrombin generation. Thrombin means thrombus, okay? This pathway of thrombin generation may ultimately lead to thrombus formation and possible thromboembolic sequelae. The antibodies, this information is very important. The antibodies that are formed may persist for weeks to months following heparin administration. Therefore, if a patient develops type 2 HIT and heparin is administered at a later date after heparin exposure within 1 to 3 months, when the circulating antibodies are still there in the blood, platelet level may decrease abruptly within hours. So the presentation of HIT, it may be early. This means the patient will develop the clinical picture and the drop in the platelet count within 24 hours of heparin administration. This is unusual. This occurs if the patient was treated with heparin recently, within maximum 30 to 100 days. The second presentation is a typical one, which occurs after 5 to 10 days after the beginning treatment of heparin. The last one is a very rare one. It's a delayed onset. It occurs several days after heparin stoppage, and this is quite strange. This is the picture presenting the early and the typical types. Here's the patient started about 160,000 and he started heparin treatment. After a few days, the platelet count become 60. It started to decrease within 5 days. The maximum and the platelets is decreasing. and so on, starting from day 5, as you see, the upper point of the graph. The upper point of the graph around 5 days it started to decrease. After 5 days, the lowest descent is 60%. Then the patient stopped heparin, so the platelet count started to rise again. After 1 month, the patient received again heparin. The platelet count was 100. 79,000. After 1 day, the platelet counts dropped dramatically into 49 after 1 day. So this is the early onset. Why? Because the patient was treated within 1 month by heparin. Okay, this is a patient with HIT. An important information: the patient may have HIT while the platelet count is completely normal. Example: if the patient has a platelet count of 450, after 5 days, the platelet count started to decrease. It became 400, 350, 300, 250. The descent, still the count is completely normal. You cannot say it's thrombocytopenia. It's out of the definition of thrombocytopenia, but it fulfills the criteria of heparin-induced thrombocytopenia. As heparin-induced thrombocytopenia means decrease less, about 30 to 40% decrease from the baseline. So we have to watch carefully the platelet count of the patient for follow-up. Okay, let's talk about the risk factors, or who are the patients who are liable to get it. For the gender, unfortunately, females are more common than male. Especially if they are admitted for surgical purposes. So the HIT is very common in surgical work than in medical work, especially after certain operations as cardiac surgery or orthopedic surgery. This is as regards the cause of hospital admission. Whenever the patient is exposed to heparin, this is considered as a risk factor, and you see the previous slide. Type of heparin: unfractionated heparin causes more incidence of HIT, and this is one of the advantages of low molecular weight heparin. It has a lower incidence of both HIT and bleeding. As regards the type of heparin, it's more common in the bovine type. It's 5 to 6 times more common than the porcine type. As regards the duration, as long as the duration increases, the incidence will increase. So,
Prof, 5 minutes more, please.
Okay, so it's the heparin. In case of less than 4 days, it's 0.2%, while more than 4 days, the incidence was 2.6. Clinical manifestation: typically the drop in the platelet count is one criteria. Number 2, evidence of thrombosis, which can occur in the venous side or the arterial side. When it occurs in the venous side, it leads to limb gangrene. Also, there will be a skin manifestation I will mention now. Also, the patient may present with transient global amnesia. For the venous thrombosis, it may affect may cause DVT in the upper extremities or lower extremities. In the upper extremities where the catheters are inserted, it can cause pulmonary embolism in 25% of patients, venous gangrene, or cerebral sinus thrombosis, or adrenal vein thrombosis leading to suprarenal infarction. As if it starts by occlusion of the vein, it will be congested. Then secondary, it will go into infarction. On the arterial side, it will cause stroke, myocardial infarction, limb ischemia. So limb ischemia can be due to arterial or venous, mesenteric occlusion, or organ infarction as in the kidney. Skin manifestation is necrosis, especially in fat-rich areas. However, it may affect other areas as the nose or distal extremities. The extremities or the skin show bluish to purple discoloration and hemorrhage and necrosis at site of cannula insertion. Clinically, as we said, lab, there is a score called the scoring system 40s. This is the scoring, and accordingly, when we count as mentioned, it tell us the probability. If it's 0 to 3, it's a low probability. It's 4 to 5, intermediate. 6 to 8, it's high probability. As regards the lab, it's a serotonin release test. This is a specific but a slow test. Although it's sensor specific, but it takes 7 days. So I cannot wait for 7 days to start on a solid ground on scientific base by the lab. So I have to shift the other modality of diagnosis, which is the ELISA, which detects the antibodies. How to treat? 4 main lines of treatment: withdrawal of all heparin preparations, alternative anticoagulant, antiplatelets, plasmapheresis. We have to stop all types of heparin immediately, whether heparin given subcutaneous or heparin infusion or flush, or even heparin coated catheter should be stopped immediately and withdrawn, because even the minimum concentration of the flush can cause a serious complication as it's immune mediated reaction. Then we have to start the alternative anticoagulant as argatropan, bivalirudin, irodine, or antithrombin or antifactor 10, new oral anticoagulant. This is the examples of the drugs. For the platelets which are activated causing the problem, we can give antiplatelet drugs. Iloprost is a prostaglandin, which causes also in addition vasodilation, or we can give aspirin or clopidogrel. These are the line of modalities. I want to stress lastly on 2 important knowledge. Although the patient may have severe thrombocytopenia up to 40, maybe it's contraindicated to give this patient platelet concentrate or blood, as it will exacerbate the situation, as it's as if you are giving a fuel. You are supplying the platelets, which will be activated by the antibodies already present in the blood. Don't give warfarin for these patients. After the discharge, patient can take warfarin, provided the platelet count is returned to normal. This is a must. For our case, the choice was argatropan. Thank you.
Thank you very much, Prof. Randa and Barbara. Are you here?
Yes, I can hear. Thank you so much, Dr. Badawi. Let me see if we have some questions for you. Hi. Does anyone have some questions for Dr. Badawi, please?
There is some question, I think is, no, I don't think there is any, is all praising the presentation, and it is wonderful one and very informative, because the HIT is very one of the most difficult topic in heparin and the heparin-induced thrombocytopenia. I don't have really here much question here. So yeah, all yours, Barbara, if you want to ask anything.
How often, Dr. Badawi, do you see this in your ICU? How often, like it, often?
Unfortunately, I see this complication in my mom. I don't work in the ICU, but this is the main reason I insist to teach the people, because it passed a note. Unfortunately, the people there couldn't diagnose it. They thought it was sepsis. Okay.
Oh my goodness, that's awful. Yes, it's this that's bad. Well, it was a very, very informative lecture. Very, very thorough. Thank you so much.
You're welcome. Thank you.
Dr. Adil,
But
do
you have a question for me? ازيك يا استاذنا اخبارك؟
Good evening to you. Any question for Prof. Makarita? He can answer. He's here already, and he can answer many questions. Despite we are very late already, you know. So.
Oh, here's there one popped up right now for Dr. Badawi. What is the mechanism of pulmonary embolism in HIT?
It's the state is the condition is a hypercoagulable state. Activation of the platelets that leads to a stimulation of the coagulation cascade. Whether it can occur, the complication, it can occur in any artery, or it may be DVT and propagated. As the thrombosis occurs both in the arterial and venous side.
Thank you. Thank you, Dr. Badawi.
You're welcome.
Are we at the point to close the session tonight?
I believe we've had all the questions that we can answer. Everyone's done a wonderful job. Thank you so much.
Thank you very much, Barbara from Ohio, and thanks for all wonderful professors and the presentation tonight. Prof. Samir Ansari, Prof. Makarita, Prof. Randa Badawi, and Barbara from Ohio, Prof. Adil Ibrahim from Emirate, and my organizing colleagues, Dr. Hisham and Dr. Walid Aswa. All of you, we are born again today, the MEGA online course. Thank you very much for coming here tonight, and all the best. Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Randa. Before this is a very short notice.
Thank you, Dr. Saad.
Thank you very much, Prof. Your pleasure.
Thank you.
Thank you very much. We are honored. Thank you.
Thank you.
Good evening. Thanks, Barbara.
Thank you for inviting me. Thank you so much, everybody.
Thank you very much, Barbara. We are honored to have you on tonight. Thank you.
Thanks.